colleagues, the cardiologists in our midst, I would have started from you. You're our visitor and probably a senior colleague. My name is Dr. Alphonsus Peter, and I'll be saying one or two things about providing clinical pharmacy service to patients with cardiovascular disease in a hospital setting. Specifically, we're talking about a resource-constrained setting, just like Nigeria. You know, our system, like we know, is a little behind, and there are a lot of things that are happening elsewhere that are not happening now. And we hope that with cardiovascular experts, cardiologists and other doctors that have interest in cardiovascular patients, and the fact that you seem to have acknowledged that we have some roles to play, it will enhance collaboration. And I think that is the way forward. I have this outline to present. You know, I would want to retire, but you can see that collaboration is one of the key things I was going to talk about towards the ending of it. Of course, we know that cardiovascular disease are the leading cause of mortality and morbidity, like the consultants have talked about earlier. And patients with cardiovascular disorder usually present to the hospital with hypertension, dyslipidemia, heart failure, cerebrovascular accident, ischemia, diabetes, arrhythmias, you know, just like you have heard from him. But these are some of the presentations that such kind of patients bring out. So it tells you clearly the patients are usually comorbid, and their management may actually be, you know, require a different approach. The American College of Cardiology strategic plan is aligned with the triple aim of improving care, improve population health, and of course, they look at lowering the cost per capita of each of the patients they see. Cardiovascular patients now present with more complications than before. The cardiologist just said that the life expectancy in Nigeria has increased in the past few years. It used to be 43, he said, to 58, but now that patients even come in advanced age after retirement with cardiovascular conditions. So what that goes to tell you is the changes that are happening in cardiovascular health. And of course, the field of cardiovascular health is emerging with more complexities. This is even the position of the American College of Cardiology 2015, where it tells you that it's even applying to our own setting as well. And more so with modernization and environmental reasons, a lot seem to be happening that were not part of our system. Now, cardiovascular pharmacists experts have emerged, you know, to address the shifting patient drug therapy needs and care. So it tells you that the patient have shifting therapy needs, like the patient may come with cardiovascular issues. Like he had said earlier, you discover that the patient had thyroid, you know, related issues, maybe thyroid toxicosis or something. Or the same patient is coming and is diabetic. Or the same patient had coming with some other complications that were not conventional in our system. And I think one other thing that is happening is that we now have better systems of diagnosis, and maybe our labs. There were a lot of ailments that were not seen before, but these days in Nigeria, we are capturing such kind of ailments. And of course, most of the time, patients in the past will tell you that this patient has spiritual problems. Some of those HLPs may not really be spiritual problems like have been said, based on the fact that diagnoses are getting better, medical practice is becoming better, you know. So I'm looking at the standards that we should look at. A standard set by American Board Certified Cardiology Pharmacy, DCC, validates pharmacy expertise to optimize patient outcome by focusing on disease prevention. You know, like the consultant said, that it's possible the disease prevention is better at the primary level, which equally includes community pharmacy, you know, and the primary outcomes that probably patients are now screening their BP, you know, and being referred or being taken care of better at the primary health care, other than they just sit down and assume that there is no threat with hypertension or with other cardiovascular threats, and they find themselves in the hospital just like that. In the past, a lot of patients only take their blood pressure in the hospital, not in the community pharmacy. And it's when they get to see themselves in the hospital when they must have had some complications that for the first time their BP is being measured or they are being asked to take antihypertensives. But I think it's changing now. So the college equally is looking at prevention, including evidence-based medication use and related care that improves both short and long-term outcomes. So that's the standard that cardiovascular pharmacists or pharmacists with interest in cardiology or working with cardiologists and other care holders should uphold. Now we look at gaps, that there exist several gaps in the management of cardiovascular patients in hospital, and one of which is the risk of adverse effects of drugs. some patients may take conventional drugs and nothing happens, but a lot of them may take and come out with some problems. The pharmacist can actually go in to look at all this and they form part of their functions in the team. Medication errors arising from comorbidity and polypharmacy. Like the cardiologist said earlier, polypharmacy is one of the issues, comorbidity and even drug interaction among the issues he mentioned. The researcher actually said it earlier that these are issues that pharmacists must look into so that they will work along with other healthcare providers in cardiovascular team so as to allow them to do other things. Assuming the cardiologist has 20 patients to see, if he's doing diagnosis and other medical related cases, if there is somebody else that is going to do drug monitoring and take care of adverse drug effects or bring out these issues, I think the cardiologist would see many more patients. Again, pharmacist interventional services regarding potential and actual drug problems are of great value. That's a research that showed that even in cardiovascular patients, when pharmacists intervene in potential or actual problems, he talked about the taking of NSAIDs in the patients just presented to us, that the patient was on diclofenac. Now there are some patients that is just on their own, that they must have taken some kind of drugs, or they may not even have significant need for them. There are other things they should have done, but they take it and it worsens their conditions. So those would actually be potential actual drug issues that come up even before they see specialists. So the pharmacist can do a lot by doing rational substitution to give some other if it's available that wouldn't need a patient taking those cardiovascular, inconsistent or non-indicated medications. Now, another way of getting out these gaps is through retrospective studies for cardiovascular diseases like heart failure, which I just talked about, stroke, diabetes, and assert baseline to assess diseases. What are we talking about here? We're talking about pharmacists that are interested in this area or work with cardiologists or the cardiovascular team, that they should not just sit down and say, oh, this is let's see what comes up. Looking at the patient folder in the inpatient or outpatient, from retrospective studies, a lot of information can be gotten, as baseline, even before the pharmacists come in. Maybe the pharmacists want to undergo such services in the hospital. Of course, some of the medical doctors will say, what are you coming to do? So one way of saying, this is what I want to do, assuming you don't have people like the cardiologist that just spoke and they want to know, you need to bring some baseline to show that these problems actually exist. It may not be every medical doctor, especially the younger ones, that may know that there are issues like that. So retrospective studies bring out unmet outcomes. For example, I've said if patients with heart failure have an average hospital stay of 21 days based on the record, how would pharmacist expertise improve or shorten the duration of stay in this new patient? So if you are able to bring out from the baseline that the patients stay in a hospital, maybe in University of Ilorin, average the patient stay 21 days, you can say, oh, pharmacy services in heart failure may reduce this. There are a lot of research you can look up to that would help your patient, and probably at the end of the day, the only way the other care providers will say that your value to our team or your addition to our team is of value is if you have your stay hampers or differentiates the results that they had when you did a baseline. So the pharmacists need to be into research to bring out some of the gaps in care systems. Of course, one other thing I talked about is knowledge, attitude, and practice research on physicians. So if pharmacists develop protocols, maybe questionnaires and research targeted at physicians or nurses, who see such kind of patients, will be able to bring out some knowledge gaps. Everybody may not be thinking the same, the practice may not be the same. But based on that, you may be able to see where you would actually work better with the physicians, the nurses, and other care providers. So it means that there is a lot of spaces and chance for the pharmacists if only you decide to do one or two research. If not, you wouldn't know, you don't assume it, especially when they are not broad, minded, or the physicians are not the type that think globally. Now, these are some of the services that you can render as a pharmacist. Potential service like drug information, patient education, drug interaction, screening. He just talked about it. The fact that he knows about the drug interaction screening means that a pharmacist that works with this consultant will actually be a better team player or can easily get to for collaboration. Drug therapy monitoring, drug and disease management, pharmacokinetic dosing adjustment, and even pharmacodynamics. So pharmacokinetic is looking at the area of what is happening to the patient drug if he has issues like kidney disorder. Just talked about that the last patient had equally comorbid hepatic disorder. So it means that a clinical pharmacist involvement in this patient, they actually help the cardiologists or the medical doctors to analyze the doses of the medications, especially if they are such that have hepatic effect. So there are a lot of grounds, there are a lot of potential, indication for pharmacist collaboration. Anti-coagulant monitoring, collaboration practice agreement. You see, I talked about collaboration practice agreement towards the end because there has to be an agreement between the pharmacist and the team, especially the cardiologists, for these roles of the pharmacist to actually, come into play and for us to document interventions. Good enough, research has documented that pharmacist involvement, especially in heart failure, has had tremendous improvement, significant improvement. So by working with the cardiologists and other care, we can always do the same thing in Nigeria. Of course, I would advise that there has to be a good practice agreement. If possible, it can be documented. It's been done elsewhere, and Nigeria is not, different. So research, pharmacists need to do research with the cardiovascular team. Just like we have talked about retrospectively, as you can do interventional studies, with doctors like Dr. Ayo, because he seems to be somebody that knows a lot about pharmacist roles and pharmacist interests. So medication safety is another area. Then formulary management. The formulary management is key. You see, American College of Cardiology has several pharmacists in their team, and these pharmacists are involved in the formulary management that you see. Most of the formulary that comes out in the US is jointly written by the pharmacists, the consultants, the nurses and other stakeholders, and guidelines. So they do not sideline the pharmacists elsewhere, and I don't think Nigeria should be different. So if we come up and work as a team, the pharmacists have a lot of role to play, So I have just given an of services that pharmacists can render. If you look at that, clinical pharmacists, their role in cardiovascular diseases, similar to what we have talked about, you can see there's patient education. Patient education is very important. A lot of patients that they see in the clinic, nobody may actually have the time like clinical pharmacists to actually provide patient education to them. Drug interaction screening, you have seen. Pharmacogenomics is one that I didn't talk about, but it's something that is evolving. Pharmacists, that's a pharmacist area, pharmacogenomics, So apart from the patient direct services the pharmacists render, there are equally facility-specific services, like research we have talked about, formulary management we have talked about, they fall into this area. There are things that the facility can implement, to enhance pharmacist involvement in patient, engagement and to improve outcomes. Then even global services. There are some services we call global services, like legal consultations, where the government and society would actually encourage the clinical pharmacists to work as, team players. So the guidelines we talked about, if it's possible, you can write formal agreements. There could be legal backing of clinical pharmacy services. And of course, what is it towards? It's only looking at making the patients better. Like we know, most of the patients that end up dying in the hospital for so many other reasons, usually they would have looked for cardiovascular consult or cardiologist consult. And it's not all the time they see them. The cardiologists are busy looking at their own kind of patient. Most of the patients usually may just die of myocardial infarction or complications. Like I've give an example, I was in the hospital and the nurses just called. The patient's relatives cried and ran and came to where we were with the nurses. Immediately, that patient had issues. He needed CPR. I was part of the team that provided CPR. And for quite some time, we ended up looking at it, kept the patient alive for a very long time. Unfortunately, I think the hospital had other issues. They didn't have enough oxygen and so many other reasons. But the point is that pharmacists elsewhere, like in Canada, I did my CPR in Canada. I'm a Canadian certified CPR provider, heart and stroke, Foundation Canada was where I did mine. And we're trained to let us know that pharmacists need to provide these services. It's not just to learn it. In a care team where you are, anybody can provide these care services. The cardiologist may be attending to somebody. What if 3 patients have issues like that? You need to provide these services just to keep the patient alive before, any advanced help is provided. still on pharmacy services, drug information. I said cardiovascular pharmacy practice require proactive updates on research. By being proactive, it means the pharmacists can always provide good information and updated information to other healthcare providers so that they get to know what's going on, what's latest. Cardiovascular relevance, I gave example of American College of Cardiology. Such kind of pharmacists need to reference to those kind of journals. I'm not saying we don't read other journals or do other things, but the attention of pharmacists in the cardiovascular team should be focused towards, cardiovascular cases. Drug interaction screening, I've said, should be mandatory for cardiovascular pharmacy practice. You don't just sit down and wait. Once you see a prescription, you screen, you bring out your concern and let the physician know about what's going on. So, commonly prescribed drugs like acetaminophen, which is our paracetamol, may react even with warfarin. So if there are patients in the ward or that are being seen, it's the role of the pharmacist to be sure that you bring that highlights to all care providers. Then the use of statins possess great risk if used with certain foods and antibiotics. There are certain kind of foods that the patients do not take with statins. The last patient we saw now was on superstatin, which is a statin. There are other statins. Some of these statins will react with certain foods and certain antibiotics. So the clinical pharmacist or cardiovascular pharmacist can always bring that to the attention of other care providers and, of course, the patient to do better. Drug monitoring. I brought the issue of anticoagulants specifically. Anticoagulants have narrow therapeutic index, like warfarin, and there's a need for INR monitoring. The pharmacist is best suited to do this. You don't expect the cardiologists or others to be monitoring INR, if they are going to attend to patients, so many patients and the other issues they have in the wards. But the pharmacist with good training can do INR monitoring. And of course, it means that when the patients come back for appointments, the pharmacist can actually be the one to attend to such kind of patients. Pharmacokinetic dosage adjustment, I said, could be gradually introduced to cardiovascular patients. You have patients that have complications like nephropathy, and other complications, and they need individualized care. Using pharmacokinetic parameters, the pharmacist can actually be a good, team player to help those patients individualize their doses. And most cardiologists within one pharmacist, people that will provide these functions so that they will do other things. Specifically, I made mention to the Cockgrove renal function. Cockgrove renal function. There is a formula we have. That formula, I think, is 140 minus the weight of the patient, minus the age of the patient times the weight. You divide by renal creatinine clearance and multiply, by renal, activity. Now, this formula is one way of doing. As for example, if the lorry does not have machine, you say, oh, we don't have pharmacokinetic machine, we are waiting. No, you don't wait. There are other ways you can do in the resource constraint area like us. Using this Cockgrove Gold formula, it will help you to assess the renal functions of your patient. So once the prescriptions are made for this kind of patients, or the renal functions, the physician that spoke earlier, the cardiologist, Dr. Ayo, talked about estimated glomerular filtration rate, function rate. So if you know the estimated glomerular filtration function rate, a lot can be done. And using this formula, you can equally get some estimated renal functions. And it will help the cardiovascular team to actually, do individualized dosing of their medications. So pharmacists can provide so many services in the cardiovascular team, including assessment of renal functions and individualizing patients' drug to their conditions. And a lot of medications that are being used in cardiovascular care are actually being metabolized in the renal pathway. Medication adherence clinic, specifically, this is a very good one for outpatient pharmacy. The cardiovascular pharmacy can actually be part of the clinics that they run. Maybe they run clinics twice in a week. It means that such pharmacists can always work with the care team. One of the services they provide is medication adherence. It will help the patient. It will help you to know to what level or extent the patient is adhering to his drug regimen or other.
Can you speak?
Okay. Can you hear me now?
Yes. I think
can you hear me now?
I'm hearing you.
Okay. So I'm talking about medication adherence clinic. The pharmacist, the clinical pharmacist or cardiovascular pharmacist.
PharmD is your network.
Okay.
We're hearing you.
How about now?
We are hearing you. Go on.
Okay, so the pharmacist can provide medication adherence services. Medication adherence services to cardiovascular patients, including lipid clinic, anticoagulation monitoring we have talked about. For lipid clinic, patients who need frequent monitoring. How about
PharmD, now? Go on. We are hearing you. It is on network. Go on.
Okay, fine. So some patients require consistent monitoring of their lipid. So it means pharmacists can actually be part of lipid profile monitoring.
What's happening? Is it network?
Hello?
Go on, sir.
Okay. So pharmacists can actually be part of managing lipid profile of the patients.
Hello, can't hear you anymore.
Can you hear me now?
Go on. We are hearing you.
Okay, fine.
They can hear you.
So apart from medication adherence clinic, pharmacists in cardiovascular team can actually, do lipid profile monitoring for the patients. It's one of the services pharmacists can provide that will spare other healthcare providers of their job. And what it means is that patients that are on statins, the pharmacists can always see them when they come for their clinic, along with the other healthcare providers. And based on what the pharmacist sees, he can always refer them back to the cardiologist in case the patient needs intervention. But by doing this, he's definitely going to spare the cardiologist the time of, monitoring patients' lipid, so that the cardiologist is able to see new patients, patients with other complications that need, urgent attention rather than just routine monitoring. The clinical pharmacist can do routine monitoring of lipid profile for the patient. Talk about medication adherence clinic. The clinical pharmacist must be able to defend the benefits of clinic to other medical. Okay, this is just a point I'm making in case the medical team is not aware, of what value the pharmacist can bring in to lipid clinic or to medication adherence clinic, or even to heart failure patients or other patients that they see. Clinical pharmacists delivering medication therapy management in cardiology clinic as independent providers led to improve in both clinical outcomes. Now, this is one research that one can look at in case you need to get information about what other pharmacists are doing elsewhere that is helping the cardiovascular or cardiology team. You can always bring that out. So I now went to the issue of the collaboration. I said collaboration is necessary to achieve patient outcomes, and pharmacists should initiate the processes of collaboration. This is because in our society, which is resource constraint area, it may not be every hospital that even have clinical pharmacists. Some hospitals barely have just 10 pharmacists. So when you tell them you want to work with their team, so we're thinking the role is just to, dispense drugs or just to correct prescriptions or bring out drug interaction information or others or drug information. No, in collaborative care, the pharmacist works very close with the physicians and other care providers. So, but then you need to let them know what I can do. So it must be initiated from the pharmacist. It's not every medical doctor that like Dr. Ayo Ogumode that knows that pharmacists can do a lot, or pharmacists have done PharmD, pharmacists have done specialist course and they can work in the team. It's not everybody that may know. So in creating collaboration, the first process is awareness. So professional awareness means that the patient, the pharmacist will have to go to the medical doctor to let them know that, I can work with you in so and so area. Traditionally, it will come from maybe when you see a prescription, you can write a consult to the physician. This patient appears to have a heart failure, and I can see he is taking ibuprofen on his own, or he came to the hospital with so and so drug, and I have advised him to stop. However, you may need to know that this is what is happening and what he's doing, or the fact that the cardiologist is seeing him and maybe another physician is seeing the patient from another department. The patient may come with two different prescriptions, and the cardiology pharmacist will write a consult and let the cardiologist know that this patient is on other medications, maybe painkillers, that may interfere with the medications she has prescribed. These are the traditional way of just knowing who the medical doctor is. Of course, he may know you based on all those small inputs you have been making. But then, for larger or greater collaboration, the pharmacist needs to go beyond that. He needs to spend time with some of these physicians, maybe in their offices, sometimes especially outpatient. Inpatients may need to do ward round with these physicians. A clinical pharmacist that is doing ward round with this physician consistently, they will likely know him. And from what he has been saying and inputs he has been making, of course, they will know whether or not the pharmacist is the type of pharmacist that they need to, that will add value to their practice. And I said the pharmacists market their potential value to the team. Yes, from what you say and your inputs, it means they would know, but these are the parts we call professional awareness. Professional awareness is letting them know the services you can render. You can render medication adherence services. You can render services like pharmacokinetic, with respect to the patients you have in the ward and the data. It will make them to know what you can do. So beyond creating professional awareness, the next step is exploration and relationship of the relationship. Most physicians would want to take the relationship to the next level if they have seen that you have talked well. Yes, you have said that there are so many things and it interests them. Different physicians have what interests them. So you may need to work with them individually and know what they want. But then some physicians may take a chance, at the pharmacist and assess the value addition and safety concerns. So in letting the pharmacist have access to the patient that the consultant is sending to him, they may want to assess, the value you are bringing, and they want to be sure that the patient is still safe, that you know a lot, not to put the patient at risk. So they may be trying to look at benefits and safety issues of the patient when they give to you. And of course, if the benefit the pharmacist is bringing is far, far higher than whatever safety concerns is, the physician will definitely feel safe to go beyond it. Then I said the pharmacist may need to give feedback to the physician. Yes, you may have worked with a physician and you have not yet seen, you may not even have had time to know whether what you have done with him, the patient is getting better. It is the role of the clinical pharmacist to go back to the physician and say, oh, patient A or B or C that you sent to us, okay, this is what we have done. This is what we have discussed this. I will discover this about the patient. We have done medication adherence to him. He's now adhering to his drugs better. The last time he saw us, he was only taking drugs 3 times in a week, but now he takes every day. And based on this, we have advised him to monitor his BP at home. This is the BP readings he has brought to the hospital. Or this is, if the physician knows that your involvement is making results, the physician will be comfortable to go beyond the awareness, and to explore the relationship further. So from sending or referring one patient to the pharmacist, the physician may send additional patients to the pharmacist, or may be more comfortable to work with that pharmacist. I say, for example, through services cardiovascular pharmacists can render, like heart failure clinic. Heart failure is a key thing. It's almost the end of cardiovascular issues. And research has shown that pharmacist involvement has helped such kind of patients. Some physicians collaborating with the pharmacist in a way that the pharmacist even adjusts medication for this kind of patients. Maybe patients with reduced ejection fraction like we have seen and are taking medications at higher doses. Over time, you discover that the patient may do better if they adhere better to their medications, which they may not have been before, or if the lipid profile is well monitored and the patients are doing better. There may be need for reduction in some of those medications. Research has shown that pharmacists have been involved in titrating such medications to the patients when they come for feedbacks, rather than the physicians doing it or other healthcare providers doing it. And it has brought results, So from one patient or 2 patients, the physician may explore the relationship beyond that patient. And maybe instead of referring just 1 or 2 patients, the pharmacist will get better or more engagement. The third point in collaboration is the expansion of professional relationship. So if, for example, the physician is aware of the pharmacy services, which is awareness, he has explored the value of the pharmacist addition and they are better off, and say, wow, I like to work beyond this point with this pharmacist. The next thing is, how will we expand the relationship? Here, it is bilateral communication. You discover that this time around, both the physician and the pharmacist must have believed in that relationship, and they may be communicating far better than they used to do, more often. Maybe this time around, if the physician sees the pharmacist's phone call or missed call, definitely he will pick. He will not say, oh, this one is a number that I don't know. He knows the number, and he will say, oh, this is my pharmacist talking. It's possible there is something he has to talk about, so and so patient. So the relationship will be better. And sometimes the physician will call the pharmacist to ask 1 or 2 other questions, and trust. Based on previous trust, I say based on previous value addition, trust is being built. So trust is being built when collaboration in cardiovascular care is going to be sustained. I said there is an avenue for more collaboration, yes, and good communication and conflict resolution skill is necessary. So communication skill is very important. The pharmacists have to develop advanced communication skill in the way they handle issues. Even when you see something that appears to be outside, there is a way you present the information to the physician that he know that, okay, we need to do something about it. Even if it's not called. So if the pharmacist, for example, has concerns, he can go bring literature or evidence-based information that would help the physician to know that this is a, evidence-based information. And most of the time, if it continues like that, they go far, far, far beyond, and it's the patient that is going to benefit. I go again and I say, for example, by carrying out joint research in patient care, pharmacists can initiate protocol for such studies by increasing services under protocol. Example, from a heart failure patient to anticoagulant monitoring. If the physician was referring only patients with heart failure to the pharmacist, he may be comfortable to even refer patients for anticoagulant monitoring because he now believes in the pharmacist's expertise. The pharmacist is able to do what he believes. He wants to try the pharmacist to explore other cases. And like we said, at the end of the day, the patient will do better because research has shown that pharmacist involvement in cardiovascular team has always had significant patient outputs, including, heart failure resolution, BP reductions, cholesterol reductions, and even quality of life. So the fourth point I brought about the collaboration is sustenance and commitment of the collaborative working relationship. Now, if the pharmacist has gone to let the physician know that I can do this, we can work, I can do this, he said, okay, he has explored it and he sees that the pharmacist, cardiovascular pharmacist benefit is actually what the patient needs, and expand the relationship to other level, to next level. It means that something needs to be done extra. And what may need to be done extra may be to commit to that relationship. How do you commit to a relationship? One way of committing to a relationship is say, okay, based on this, let's write a protocol. I had an intervention I made in a hospital in Jos, and during my PharmD training, most of my classes were done there, and my MSc research was in cardiovascular, cardiology. So both my PharmD was a medication adherence, among hypertensive patients. So I worked close with most of the cardiologists and the physicians that were seeing the cardiovascular patients. I was able to establish a very good relationship, that most of the time when I recommend to them, they don't even ask questions again because we had built that trust. We had gone from just an awareness stage to the second stage, which is exploration. They had explored and they believe in what we were talking about. So we needed to carry it to an expansion level. So what we did was that I recommended to the hospital team, to the physicians, about the role of pharmacists in the cardiovascular patients they see, especially the diabetic patients. So they accepted and they had a meeting. Subsequently, they agreed that any patient in that hospital that was going to be taking insulin and some other medications must be referred to the pharmacist. And some of the patients on the sulfonylureas, because of the side effects of sulfonylurea, sometimes they can just drop sugar levels.
Dr. Alphonsus.
Yeah.
Yes, so can we wrap this up now?
Okay, yes, so I'm almost coming to the end. So they got to the point that the medical team referred such kind of patients to the pharmacy department. So it is left for the pharmacy department to take that relationship to the next level and maybe to do some consultation. But I don't know to what extent that service is now in the hospital. But as at that point in time, they were comfortable to refer such kind of patients to the pharmacists that were in the cardiovascular team because they believed that it was going to bring positive outcomes to the patient. So to sustain it, one way of doing it is by writing a collaborative agreement or by doing some documentations to say, since we now get results, let us do it to so and so number of patients for so and so number of time, maybe 2 years or 3 years. So if you have new medical doctors, new house officers, new teams coming, they know that there is a documentation like this, that pharmacists and the physician are in a collaborative relationship. The physicians refer some kind of patients to the pharmacists. Pharmacists do medication adherence consult for cardiovascular patients, and they team up. And most of the time, they can even do research. They can research to bring out what they have done, and it becomes documented. And they jointly publish the research. Such research is both the cardiologists, the clinical pharmacists in the cardiovascular team, and maybe the nurses or other people that are there, and they jointly publish it. If you go online, you see a lot of research that have been jointly done by physicians and the pharmacists, especially when it brings out interventional pharmacist intervention in cardiovascular patients, that maybe heart failure patients or patients maybe with anticoagulant monitoring or lipid profile, monitoring, and so many other interventions that the pharmacists have done. So I would advise us to key into it, try it in our place of work, and I'm sure we're going to get results. So one way of doing it, a quick SWOT analysis may be done for the cardiologist or resident, looking at what SWOT means: strength, weakness, opportunity, and threat. Strength, weakness, opportunity, and threat. So different physicians have different strengths. You need to be able to acknowledge that. what is their weaknesses. One common weakness with most cardiologists or most physicians is that they may not have enough time for the patient. They may be thorough in, or they may just see a few patients at the end of the day because they want to give the patients the best. But Nigerian system, how many cardiologists do you have for one patient? If you do the research, you will discover that cardiologists are very scarce in Nigeria. So it means that there is a gap there. Most cardiologists may not give their services to all the kind of patients they want to give. So the other aspect, like monitoring of the patient, can actually be done by other care providers like pharmacists. So if the medical doctor or the cardiologist spends a lot of time with the patient, the weakness is that he may not see so many patients in the whole at the end of the day. So by subletting some of these services or collaborating with pharmacists, the cardiologist will see several other patients, maybe double the number or 3 times that he used to see, instead of spending 1 hour counseling patients on the use of drug, adhering drug lipid profile. The pharmacist can always do that. So a SWOT analysis of each of these physician and care team will give pharmacists more information about how to go with these medical doctors. Even the nurses, cardiovascular nurses are still there. There's some of them that you have to do your SWOT analysis to know how best you can work with them and what value you can bring to the team. I said as the collaboration advances, pharmacists may document agreement with physicians to initiate, modify, or document drug therapy for the patient. It is what is being done elsewhere. Nigeria is not immune to changes. Just like we know COVID-19 has come, we are now doing Zoom. Before COVID-19, I don't know if we would have been doing this. So it tells us that necessity is the mother of invention and that change is a continuum, and we'll continue to do that. And lastly, when it comes to cardiovascular team, one research has shown that patients with heart failure usually get readmitted to the hospital more frequent than most ailments. Heart failure is actually a disorder that the quality of the patient is usually an issue. And like the consultant said, there are on so many medications. For the pharmacy, they may go back to do 1 or 2 personal care, self-care, or self-medications. And research has shown that they usually come back too quickly to the hospital. And pharmacist involvement has actually reduced patient readmission by about 30%, 33%. So if pharmacist involvement can reduce patient readmission by 33%, it goes to show that the cardiology team can work best with the pharmacist, especially with respect to patients that are being discharged. So any patient that is going to be seen, we call it seamless care, post-discharge patient, the clinical pharmacist should be the last patient, the last care provider that this patient should see. So the cardiologist and cardiology team, the pharmacist will need to let them know that he may need to see those patients post-discharge so that he is able to look at their drugs, he reconciles their medication, look at what is being duplicated, look at what is supposed to be given and is not being given, and takes the last decision. And again, the pharmacist may need to even consult or get across to this patient, even when they are outside the hospital setting, with respect to knowing how well they take their medications, and even the next hospital visit and what else they do. If you do so doing, by so doing, you should look at it with what we talked about, the initial research of taking baseline of the patient. You discover that the patient that used to come back to the hospital for fresh admission in the same case may no longer come like that. It may now be maybe the patient to be stable, and the same patient may not come back for readmission based on complications of heart failure. Rather, it may be new patients that the cardiologist will see and the cardiology team will be seeing. So for us to know that collaboration is the importance of collaborations and the impact are significant, and we should try it consistent. It shouldn't just be based on assumption. We should not be saying we'll do it. Let's try it today. Let's start by creating an awareness. From awareness, that awareness can be expanded. From expansion, we know that you can take it to the next level, after it's been explored, and maybe come to an agreement. At the end of the day, even the modification of the medications may not be a very big issue, because the cardiologists and others would have the time to see so many other patients and so many other cases. In fact, they maybe have the time to travel to some other hospitals. I know of hospitals that have some satellite hospitals that need cardiologists. Sometimes they don't go because they don't have the time. Even if it's once in a week they go, they can keep such kind of patients for them. If you have pharmacists that work with the team, most likely the cardiologists will have the time for newer patients, newer cases, and routine drug monitoring can be done by clinical pharmacists. And like we said, research has shown that patient readmission for the same heart failure or cardiovascular cases may actually be reduced by pharmacists' involvement and engagement. Studies have also shown that the role of clinical pharmacists in cardiac rehabilitation team, where they provide acute renal coronary syndrome patients education, adherence consult, and resolving drug therapy give significant result. So lastly, we talk about what are the qualities of cardiovascular pharmacists. You have to be bold. If you are not bold, you'll not be able to say, this is what I can do. Be ready to build long-term relationship, develop strong interpersonal relationship, develop patient assessment skills, inspection, palpation, osculation. The pharmacists need to do all these things, not because you are diagnosing patients, but because you want to monitor. The monitoring of this patient will actually help the clinical pharmacist to get back to the consultant. Yes.
Yeah.
So, conclusion, enables greater efficiency of the physician and provide attending patients with cardiovascular disease. So by putting pharmacists, you get better results through optimization of drug therapy. So thank you.
Dr. Alphonsus.
Thank you for listening. We are hoping that you give cardiovascular collaboration patient care a trial. I can always come to us advice on how we can do it.
Thank you very much.